about 6 and 10 this year at best. And I firmly believe the best music of all time was made in the 60s and it's been downhill ever since. And neither the glass to you, the cheese, nor the Beatles paid me anything to say that. But it is great to see you all here this morning. It's great to have such a terrific collection of speakers and guest lecturers from some of the very best people from around the nation, international experts, and congratulations and thanks to Dr. Lacray for putting together a program that is absolutely world class. What's also great, though, is the opportunity to visit with and get together with some of our outstanding local physicians and experts in the area, and I'm particularly honored to be bracketed between Bill Stites and Bill Brodeen, two really outstanding local electrophysiologists and good friends. You know, personal friendships and professional relationships are terrifically important, and that leads to this part of the program, the presentation of the Manohar Gowda Memorial Award. Manohar Gowda was born in Nashville, Tennessee. He was trained at Florida State University and went to medical school at the Menohar College of Medicine in Tennessee. He was first an internal medicine resident and then a fellow in cardiovascular diseases at the University of Missouri, Kansas City, and St. Luke's Hospital in Kansas City, Missouri, in the late 1990s and early 2000s. And that's when Dr. Lacray and I and many other people who got to know this really outstanding young physician. He was first and foremost a dedicated and compassionate doctor who provided excellent care to his patients. Over the course of his training in Kansas City, Dr. Gowda published 9 papers in peer-reviewed journals, including the American Journal of Cardiology, the American Journal of Medicine, Archives of Internal Medicine, and he authored 18 abstracts presented at national meetings, including the American College of Cardiology, the American Heart Association, and the American Federation of Medical Research. He was just an amazing clinical investigator. In addition to his clinical skills and contributions to cardiovascular research, he is remembered by all who knew him as a brilliant, insightful, and extremely hardworking young man. He was rarely seen without a smile and was unfailingly kind and thoughtful to everyone with whom he interacted. He passed away in a very untimely and tragic fashion in the fall of 2002 after finishing his fellowship training. He went back to his hometown of Nashville to begin private practice of cardiology. Thanks to the generous contributions of family and friends of Manohar, we are pleased to announce the 2nd annual Memorial Young Investigator Cardiovascular Research Award. And this award has been established in appreciation of the late Dr. Gowda's contributions to cardiovascular research, both as an investigator and a mentor for other young investigators. And I know I speak for DJ when I say it really was, I think, high points of our careers to have a chance to work with this terrific young doctor. And he would be so pleased to know that his legacy is fostering ongoing clinical investigation by trainees. This year we had 18 abstract submissions. They're all outstanding. There was a team, a panel of folks at KU chosen to select the abstracts, and it was a difficult process, but we did come down to the top 4. The honorable mention was from Dr. Jisral Singh from KU. His abstract was radiofrequency ablation in patients with recurrent symptomatic atrial fibrillation and gastroesophageal reflux disease, irritable bowel syndrome, the heart-gut connection. Dr. Singh here. Come up and get your award, my man. part of his award is he doesn't have to present his abstract, which is not true for the third place winner, which is Dr. Luigi Diaz. The presentation will be given by Dr. Pasquale Stacchindelli from the Texas Cardiac Arrhythmia Institute in Austin, Texas. The abstract is Endo-Epicardial Homogeneization of the scar versus limited endocardial substrate ablation for the treatment of electrical storms in patients with ischemic cardiomyopathy. And if we can bring up this presentation, because we're going to make you do some work this morning. Thank you. Good morning.
I have a disclosure for this topic. So basically, catheter ablation of electrical storm on high volume atrial tachycardias in patients with ischemic cardiomyopathy has demonstrated just moderate long-term efficacy. In particular, if endocardial ablation fails, it is still unclear whether there is a reconduction of an isthmus in the endocardial site, so incomplete ablation of all the endocardial substrate, or rather due to the presence of an epicardial substrate. The aim of this study was to investigate the impact on recurrences of two different substrate approaches for the treatment of these arrhythmias. We studied 92 consecutive patients with ischemic cardiomyopathy and electrical storm or high burden clinical ventricular tachycardia. The definition of electrical storm was conventional, more than 3 ICD intervention in 24 hours. And patients were treated either by confining the radiofrequency lesion to the endocardial site to transect the critical isthmus, which is standard VT ablation, or with endocardial and epicardial ablation of all the potential abnormal potential within the scar. This is called homogeneization of the scar. Group 1 is 49 patients, and group 2 is consisting of 43 patients. Basically, the methods in group 1 was a conventional standard ablation. We tried to identify the critical VT exit sites, and we did a short linear ablation across the VT isthmus to terminate the clinical VT. In case of inducible clinical VT, after standard endocardial ablation, we went epicardially, and standard epicardial ablation was performed in 4 patients, 80% of group 1. In group 2, after ablation of the clinical VT, ablation was empirically extended to all the scar, targeting all the fragmented, delayed, and abnormal potential within the scar, basically to homogenize all the abnormal substrate. Epicardial access was obtained at baseline in all patients, but epicardial ablation was performed only in 14 patients, or 33% of cases. In both groups, after ablation, the acute procedural endpoint was the inducibility of any sustained ventricular tachycardia before and after the administration of azepoterol. All patients were followed up with remote monitoring as well as implantable device interrogations, and arrhythmia recurrence was defined as any symptomatic arrhythmias or arrhythmias receiving device-based treatment, which was APP or shock. And these are the baseline characteristics in the two groups, where a patient were a consecutive patient, and two groups were completely similar with respect of baseline clinical characteristics, so age, percentage of males, importantly, left ventricular ejection fraction, and medication use. So basically, both groups were comparable for baseline characteristics. With regard to procedural characteristics, again, both groups were completely comparable with regard of percentage of sustained ventricular tachycardia, inducibility of VT, localization of the scar, but importantly, the procedure time was obviously longer in patients with homogeneization of scar, in which extensive substrate ablation was required. Again, fluoroscopy time was longer, and also the frequency time was about 20 minutes longer. And this is the long-term success of these ablation strategies. At 25 months on average of follow-up, 23 patients of endocardial substrate ablation alone had VT recurrence 47%. And this is quite consistent with what we already know of the long-term outcome of this group of patients. But interestingly, patients receiving Endo-Epicardial homogeneization scar, only 19% VT recurrence, with significant difference regarding survival with the log-rank test. And this is the time to event analysis according to Kaplan-Meier methods. And we saw that, again, patients receiving Endo-Epicardial homogeneization scar and especially a better long-term outcome free from ventricular or recurrent ventricular tachycardia. After adjusting for potential confounders and covariates, both at baseline characteristic, clinical, and procedural, again, Endo-Epicardial homogeneization scar was associated with significantly lower risk of recurrence, and basically for 62% relative risk reduction as compared to limited substrate ablation. This example patient of group 1 limited substrate ablation. This patient clinical isthmus was identified for the clinical VT, which is shown in column A, and then ablated to the extended isthmus. In group 2, along with the ablation of the isthmus, ablation was extended to an entire scar targeting the normal potential, which is fragmented, delayed, and late potential inside the scar. And this is only endocardial. And this is the Endo-Epicardial homogeneization scar. Again, the patient, the ablation was extended to hold the normal potential in both endocardial and epicardial sites. So in conclusions, our study demonstrates that ablation using the Endo-Epicardial homogeneization scar significantly increases long-term freedom for recurrent ventricular arrhythmias in patients with ischemic cardiomyopathy. Thank you.
Thank you very much. You know, in view of the schedule, I think we're going to move ahead with the presentations, but as a break follows this, I might ask that the award winners stay near the back room by the abstracts, so that anybody who has questions, they can discuss them with them then. Thank you very much for that outstanding bit of work. The second place winner was Dr. Salva Malhotra from Indiana. The abstract was temporal relationship of fragmented QRS and microvolt T-wave ultranams with acute ventricular tachyarrhythmias after experimental myocardial infarction. And Dr. Malhotra wasn't able to attend today, but we will make sure that the award is presented. So the first place winner, really an outstanding bit of work, was will be presented by Dr. Stavros Stavrakis from the University of Oklahoma Health Sciences Center. His abstract was inhibition of atrial fibrillation inducibility by low-level vagus nerve stimulation, the role of nitrate oxide signaling pathway.
I will be talking about inhibition of atrial fibrillation inducibility by low-level vagal nerve stimulation, the role of nitric oxide signaling pathway. And before I start, I would like to thank and acknowledge my mentors, Dr. Sunny Cole, Dr. Bernd Sherlock, and Dr. Rafa Zara from the University of Oklahoma. I don't know a disclosure slide, but I don't know any disclosures. So atrial fibrillation is one of the most prevalent invasive cardiovascular conditions. The existing treatment options for atrial fibrillation include medications and catheter ablation, which consists mostly of pulmonary vein aspiration, plus or minus catheter ablation, as we heard yesterday. Each one of these treatment options has limitations. Specifically, pharmacological therapy is limited by inconsistent efficacy and potential toxicity, whereas catheter ablation, while more efficacious, is associated with potential risk of serious complications, up to 6% based on a recent worldwide survey. Moreover, the long-term efficacy of catheter ablation has been rather disappointing. Two recent studies have been published which show that the 5-year success after a single procedure ranges between 29 and 46%, which is not very good. So, non-pharmacological, non-ablative therapies might seem very attractive. Although vagal nerve stimulation, which slows the heart rate, has been used for decades to induce atrial fibrillation, recent evidence suggests that low level of vagus nerve stimulation, 10 to 50% below that, which slows the heart rate, has antiarrhythmic effects, which makes it a potential novel treatment modality for paroxysmal atrial fibrillation. As shown in this figure here, it's from a canine model of atrial fibrillation from our group. Low-level vagus stimulation reversed and also prevented atrial fibrillation inducibility by rapid atrial pacing. However, the exact mechanism and the downstream targets of low-level vagal stimulation remain unclear. Nitric oxide facilitates vagal neural stimulation at the presynaptic level within clusters of neurons on the heart surface, which are called ganglionated plexi, or GP. Also, we know that nitric oxide mediates the protective effect of vagus nerve stimulation against ventricular fibrillation. The phosphorylated inositol-3 kinase, or PI3K, activates nitric oxide synthase. Therefore, we examine the role of PI3 kinase and nitric oxide signaling pathway in the low-level vagus stimulation mediated inhibition of atrial fibrillation inducibility. In this series of experiments, 17 adult Montreal dogs were anesthetized with sodium endocardial, intubated and mechanically ventilated. Bilateral thoracotomies allowed insertion of catheters in right superior, right inferior pulmonary veins, left pulmonary veins, and both right and left atrial appendages. The right vagus nerve trunk was dissected from the pelvis sheath, isolated at the cervical level, and we inserted a pair of Teflon-coated silver wires for stimulation. And we defined low-level vagus nerve stimulation as the voltage 50% lower than the voltage that slowed the sinus rate. This schematic shows the experimental design. The animals were randomized in 3 groups. All 3 groups received 6 hours of rapid atrial pacing. In group 1, during the last 3 hours of rapid atrial pacing, low-level vagus stimulation was applied. In group 2, the nitric oxide synthase L-name was injected in the anterior right and inferior right GP, along with low-level vagus stimulation. And in group 3, the PI3 kinase inhibitor warfarin was injected in the anterior right and inferior right GP. Now, after each hour, rapid atrial pacing was temporarily stopped, and programmed electrical stimulation at all pulmonary vein atrial junctions and right and left atrial appendages was performed to determine the effective refractory period. This is something that we do in the EP lab as well in patients. And we also determined the window of vulnerability, which was defined as the long longest S1, S2 minus the shortest S1, S2, which induced atrial fibrillation. At the beginning, baseline, and at 6 hours, we applied acetylcholine 100 nanomolar on the right atrial appendage to induce atrial fibrillation, and we documented the AF duration. And both these methods of AF inducibility have been previously validated. We also assessed GP function by constructing voltage sinusoidal curves by applying high frequency stimulation on the right, anterior right GP by incremental voltage levels until AF was induced. And maximum percent change in sinus rate was a surrogate marker of GP function. Coming to our results, as you see here in this figure, the cumulative window vulnerability increased sequentially in all three groups, and it decreased significantly towards baseline in the low-level vagus stimulation group. NO failed to have any effect on AF inducibility during the 4th hour, but it attenuated the low-level vagus stimulation mediated effect during the 5th and the 6th hour. Likewise, warfarin did not have any effect at the 4th and 5th hour, but it did attenuate the effect of low-level vagus stimulation during the 6th hour. Again, shown here, low-level vagus stimulation decreased AF duration by about 9 minutes to 1 minute, an effect which was highly statistically significant. And both L-name and warfarin blunted this suppressive effect. There was no difference between baseline and 6 hours in the presence of L-name or warfarin. Also, low-level vagus stimulation suppressed the ability of high-frequency stimulation of the anterior right GP to decrease the heart rate, as shown here. And both L-name and warfarin blunted or inhibited this effect. So, in conclusion, the antiarrhythmic effects of low-level vagus stimulation may be mediated by PI3 kinase nitric oxide signaling pathway. And this data may provide new insights into the role of neuromodulators in the pathophysiology of atrial fibrillation, and may form the basis for the development of new therapeutic targets for atrial fibrillation.
Excellent work, Dr. Saprakis, and thank you very much. I know Manohar will be very proud of the work that these investigators have done, and I suspect that they will have outstanding careers. We're pretty much on schedule, so it's time for a break. We'll see you back in 10 minutes. Thank you very much.